Sorry. So we are live now. Over to you, Vijaya. Sujaya, over to you. You're muted.
Yes, ma'am. Yeah. A very good afternoon to all the faculty and delegates who logged in today afternoon. So this is Searchlite 38. It's updates on Placenta Accreta spectrum disorders, cancer prevention in association with Cancer Prevention and Relief Society and Bhimavaram and Raipur OB-GYN societies.
So I would like to introduce my convener, Dr. Sujayasri Sangita, who's the secretary of Bhimavaram Society, and she has been associated with me since Searchlight 3. So welcome, Dr. Sujaya.
Thank you so
He
much.
is a consultant obstetrician and laparoscopic surgeon at Sheshadri Hospital, Palakol, and Sheshadri Hospital, Malikapuram, founder secretary of Bhimavaram Obstetric Gynec Society and secretary of IMA Palakol. She has Shan as Ratnam Young Gynecologist Award, Foxy Dira Award. Her areas of interest are laparoscopy and infertility. She has presented papers at AICOG 2011, 2012, Yuva Foxy, and many others. She is the organizing secretary of GUSA 2016 and 2018. She does a lot of community work, conducting awareness programs, Vikasam for adolescent girls. This program has received award of recognition by District Lions Club. Welcome, Sujaya.
Thank you for that kind introduction. So it gives me great honor to introduce the program director, Dr. Asha Jain, ma'am. She is currently the chairperson of committee for drug medical surgical equipment. Madam has recently been elected, so congratulations again, ma'am. And
thank you. I'm not current. I am CP elect. I would take over in January.
Fine, ma'am. So right now, Madam is the director of SMSA Hospital, Raipur. She is also the medical director of Cancer Prevention and Relief Society, elected member of CG Medical Council. She is also the elect of Foxy Food Drug Medical Surgical Equipment Committee. As I said, she's the elect chairperson, president of Raipur Menopause Society, chairman Mission Pink Health, IMA Raipur, and also the executive member of ISPCP, Chhattisgarh, ISAR, and SFM chapter. So, Madam has she's received training in colposcopy. She has also received certification in IOTA. And Madam is also received certificate of competence from the Gynac Academy in Gynac Ultrasound, fetal medicine, and obstetric ultrasound. And Madam's areas of interest are preventive oncology, colposcopy, saving the uterus, fetal medicine, and obstetric and Gynac ultrasound. And ma'am, please take over and perform the inaugural function. Ma'am, you're muted.
we start the program by prayers to the divine. It's Ganpati Utsav already going on, so we start with 1 minute of prayer before we take the program forward. I would also like to introduce my coordinator, Dr. Purvi Agrawal, who's an executive member of SFM Chhattisgarh. She is a fetal medicine specialist trained under Dr. Adinarayan Makam. She is director and consultant at Krishna Fetal Medicine Center, executive member SFM Chhattisgarh, past IFS executive member, IOTA and FMF certified. She's trained in fetal procedures, done many national and international publications, and she is a training faculty for ultrasound at my hospital for FOXY certified training. So welcome, Purvi. There has been an emergency at home, so she's not been able to join in today. And now I would like to, Suja, would you please do the honors and introduce Lakshmi ma'am?
So we begin the first session for today, and I would like to introduce the chairperson, Dr. Lakshmi. Ma'am, next slide, please. Yeah. So Madam has done her master's from JIPMA, and she's also completed her MRCOG. She's a consultant at Sri Lakshmi Hospital, Bhimavaram, inaugural president of Bhimavaram OB-GYN Society. And as previously mentioned, she's done it from National Institute, JIPMA, Pondicherry, member of Royal College of Obstetrics and Gynecology. She's participated in several national and international conferences as a faculty. She's received Best Paper Award in the World Congress of Infertility, which was held in Mumbai in the year 2004. She has 20 years of experience in the field of obstetrics and gynecology, and her areas of interest are high-risk obstetrics and urogynecology. She's well-versed in techniques of non-descent vaginal hysterectomy and minimal access surgery. So welcome to today's session, ma'am. And I would request you to please introduce the speaker.
Thank you so much, Dr. Sujayasri, for the kind introduction. Today's topic is very important for every obstetrician because it causes life-threatening peripartum hemorrhage, and we have seen drastic increase in the incidence of placenta accreta in the last decade, thanks to the rise in cesarean section as well as ART conceptions. And definitely, it is a nightmare for every obstetrician who is practicing high-risk obstetrics. And ultrasound is an essential tool for the diagnosis of placenta accreta, as it is simple, non-invasive, and also it is cost-effective. However, the reliability is based on the expertise of the sonologist and also the resolution of the machine. So today we have with us Dr. Megha Kamlapurkar, who will give us an update on the role of ultrasound in the management of placenta accreta spectrum disorders. So, Madam,
Lakshmi ma'am, your voice is breaking. Your voice is breaking
from Aurangabad University. She is presently the founder, president of... Hello?
Hello, ma'am.
Yeah, ma'am, your voice was breaking very badly. Please look at the screen and speak, ma'am. It's displayed on the screen. Lakshmi ma'am?
Ma'am, are you...
So I would like to say that I met Megha ma'am at
Yeah.
a conference and I was
she-
really
Yeah.
impressed
Am I audible
by...
now?
Yes, ma'am.
Yeah, ma'am, please go ahead, ma'am. Dr. Lakshmi, ma'am, please. I think there must be a network issue, ma'am. So I will just introduce.
Yeah. She is also the Chairman Advisory Committee of
Her voice is breaking very badly.
Beyond.
Sujaya?
Yes, ma'am. I just introduced Madam Dr. Megha Kamlapurkar. I hope I got your name right, ma'am. She's the director of Devata Hospital. And Madam is a gold medalist from Aurangabad University. She's presently the founder president of Isobar Kalburgi chapter. She's also the chairman of Fetal Medicine and Genetics Committee in Karnataka, chairman advisory committee PCPNDT. Devata Hospital is a Foxy recognized training center for ultrasound, and Madam has been UK certified for NT and anomaly scan. And Madam is also interested in Hindustan classical music. So Madam has a creative side too. So welcome to today's program, ma'am, and we're looking forward to hear from you.
Welcome, Dr. Megha. I was
you.
impressed with you from the very beginning when I met you and really glad to have you here. So I've stopped screen sharing and you may proceed and share your screen.
Same is true with ma'am. True with me. I was impressed by your beauty inside out, you know. Is it seen?
No, ma'am.
Respected
Not
Asha
seen,
ma'am.
Now it's visible.
Not seen.
Yeah,
Now it is seen, ma'am.
Ma'am, you can make it full screen, ma'am.
Screen is seen, no?
Screen is seen, it is not full screen yet.
It's full screen.
Now it is full screen. You may proceed, Dr. Megha.
Okay. Okay. Good afternoon, everyone. At the outset, I would like to thank Dr. Asha Jain ma'am, whom I met in Dehradun, and I was also impressed for her beauty and brain, and I really I congratulate her for being elected for this new job as a Food and Drug Committee Chairperson of Foxy. I'm really fortunate to be the speaker in this esteemed Searchlight meetings, and today is the 30th episode, and we'll be talking about ultrasound in placenta accreta syndromes. I always feel placenta is like a naughty child. If we ignore that, then it will create a havoc and will seek our attention. So coming to this placenta accreta syndrome, as our chairperson has rightly said, that the incidence is increasing, though less, it is increasing because of the rising incidence of cesarean sections. And despite the knowledge about the placenta accreta syndrome, despite of using the technology, still 50% of the placenta accreta syndromes are undiagnosed till the delivery, till the cesarean section, and only 10% of them, they are overdiagnosed as placenta accreta syndrome. The intention of today's lecture is to help our own friends, ultrasound operators, not just to identify the placenta accreta syndrome, but to be aware of each of the sign, its significance, and then have the topography of the placenta, map the placenta, and help our friends who are going to operate on that lady, as we do fibroid mapping and help the laparoscopic surgeon to find out the fibroids where they are. So same way we'll be just discussing the various signs which will be seen in ultrasound placenta accreta syndrome is concerned. So abnormally invasive placenta is a clinical term used to describe the placenta that does not separate spontaneously at the delivery and cannot be removed without causing any abnormal heavy blood loss. The alternative term was morbidly adherent placenta, and this is a good paper which describes the proposal for standardized ultrasound descriptors for abnormally invasive placenta. So the two terms like AIP and morbidly adherent placenta, MAP. They are clubbed under the name as Placenta Accreta syndrome, which includes abnormally adherent placenta, which includes Placenta Accreta, and abnormally invasive placenta, which includes Placenta Accreta and Percreta. So as we can see here, that depending upon the placental invasion, this placenta Accreta syndrome has been described. This is the placenta which is invading, and it is just adherent with this endometrium or myometrium. This is the endometrium and this is the myometrium, and then here it is invading, whereas the invasion is crossing beyond the serosal border, and depending upon that we classify this as the normal placenta, where we can see this as a placenta, clear-cut demarcation as endometrium, myometrium, and serosa, whereas in Accreta, there is an adhesion between the placenta and the myometrium. When in Accreta, the myometrium is being invaded by placenta, and in Percreta, it crosses still beyond and can go beyond the serosal margin. So depending upon various studies are there to report the incidence of placenta Accreta syndromes, and one of the studies says that the incidence is 0.79 to 3.1 per 1,000 live births, and 4.1% in women with one prior cesarean section, 13.3% in women with 2 or more previous cesarean deliveries. The various data is available, but the risk of placenta Accreta syndrome or PAS in subsequent pregnancy increases obviously with the number of cesarean sections. That is, from first cesarean section, it is 3% for 1, it goes to 11% for 2, and 40% or more than that if she has 3 or more cesarean sections. But 50% cases, as I have told, they are undiagnosed till we operate the patient or till she delivers, and 10% are being overdiagnosed because of the various placental signs that can be as well seen in normal placenta. So what can be the pathophysiology? We all know the blood supply of the uterus starting from the spiral arteries, then basal arteries, then radial artery, arcuate artery, and then ovarian arteries. So partial or total absence of the decidua basalis and a defective development of the fibrinoid or the Nittabux layer results in abnormal firm adherence of the placenta to the myometrium. The defects in the biological functions of the trophoblast, if they exceed, they can lead to excessive invasion into the myometrium. There will be shift of placental blood supply from this tiny spiral artery, which is seen in normal placenta, to a larger and deeper radial artery or arcuate artery, which has got very high blood flow velocities. So what will happen? There will be high velocity blood flow in the uteroplacental circulation, and in the placental lacunae will be seen. And there will be hypervascularization pattern under the placental bed also that can be picked up by color Doppler. So as we all know that what are the risk factors for PAS, we need to know when we do the scan for the patients. We need to take into consideration the history of previous cesarean section, or there is a history of uterine anomalies, previous uterine surgeries, dilatation curettage, myomectomy of the maternal age more than 35, multiparity, and one more, IVF pregnancies also increases the risk of placenta Accreta syndrome. So these are the red alert for the sonographer. Apart from this, we are now, it is of biochemical testing for aneuploidies, and apart from aneuploidies, they do help us for predicting other conditions as preterm labor, preeclampsia, or placenta Accreta syndromes. So when we have raised PAP-A or raised beta SCG levels, or elevated alpha-beta-protein levels in mother's serum, then we should have our antennas alert, and we should be looking for the placenta and its location and its invasion if at all it is in the lower segment. The difference between, of course, the placenta Accreta and Accreta can be confirmed by histological findings, and the definitive clinical diagnosis can be only made after delivery, and it should be confirmed by histopathology whenever we deliver the patients. So why antenatal diagnosis of PAS is important? An accurate and early prenatal diagnosis of PAS allows time for a multidisciplinary team to plan delivery of the lady in a center with an expertise in surgical management of these disorders. As such, surgical complications, blood loss, requirement for transfusion, hysterectomy, and intensive care stay for that patient can be reduced after antenatal diagnosis compared with those women when the diagnosis is made during the intrapartum period. What is the timing ideal for the ultrasound scan for screening or no? The patient has passed. The optimal time for evaluation of placenta accreta syndrome is between 28 to 32 weeks of gestation, because evaluation of placenta before 28 weeks of gestation is limited owing to its incomplete placental maturity, and it can be challenging after 32 weeks because of the late gestation. So owing to the overlap of the features of late gestation and past, because sometimes normal placenta also can show few signs of placenta accreta disorders. So in women with previous cesarean section, ultrasound examination is mandatory in first trimester of pregnancy, which can, where we can look for the cesarean scar pregnancy, which is a precursor of our PAS. So this can facilitate the timely detection, counseling, management, and referral, although we cannot subject it for each patient, for each center and everywhere because of the cost effectiveness. So ultrasound diagnosis is ideal after 28 weeks of pregnancy to reduce the false positive diagnosis. 2 or more signs of placenta accreta syndrome are seen in normal placentation in 98% of the cases. So most signs of placenta accreta syndrome are seen in third trimester, but the screening should start right from the first trimester. So past disorder, according to the degree of severity, is classified into various grades by FIGO and Society for Pediatric Pathology. Here we can see the placenta under the grade 1 by both the societies, where we can see this is the placenta, yellow line is endometrium and gray line is the myometrium. So here the placenta is just adherent to the myometrium. It can be classified as grade 1, both the societies classify them as grade 1, whereas grade 2 corresponds to the myometrial invasion, and grade 2 and grade 3A SPP or Society for Pediatric Pathology, where myo-invasive grade 3A the invasion is much more deeper in the myometrium, going beyond the serosa, and here it is going beyond the serosa and invading the adjacent structures. The SPP or this society has removed grade 3B. Here we cannot see 3A and directly 3D, 3B and 3C. They have deleted because they have included them under grade 3E. So this blue line is FIGO classification for past disorders to know the degree of severity and to manage or plan the operative protocol for that patient. So prediction topography is important for the placental invasion, which will help for the preparation of multidisciplinary approach and how much to do the surgery and how should we be prepared for the blood loss that we may encounter during delivery. What happens? We do the scans. Actually, I also used to look in the fetus. I was very much interested to look into other anomalies. And then at the end of the procedure, I used to forget placenta. Again, I used to call that patient, again, see for the placenta where it is. So we just overlook the placenta in our routine scans. So before we go for past signs, we need to know how normal placenta looks. We can see that normal placenta ecotexture is homogeneous. We can see that there is a space behind the placenta that is called retroplacental halo, and we can, beyond that, here is the retroplacental halo, and beyond that we can see the myometrial vessels, and beyond myometrial vessels we can see this echogenic line, which is nothing but the serosa. Here also we can see, and what happens, the myometrium is hypoechoic. We can see this myometrial vessels, we can see these myometrial vessels beyond or below the placenta. Because these vessels are large, they look like a hypoechoic spaces behind the placenta. So if we put the color, we're picking up those myometrial vessels. So normal placenta, one more thing is we should see the placental lower edge. And where is the lower edge of the placenta? Is it coming to the lower segment or not? And that picture we should give in our report to say that the placenta is well away from the internal os, and placenta, low-lying placenta is ruled out. So this is how we need to have the details of the topography, the location of the placenta. We can see the whole placenta is being evaluated right from this fundal end to the lower end of the placenta, which is away from this cervix in this case. So when placenta is posterior, we need to be little careful. Here we can see the placenta is homogeneous. We can see equiescent space behind the placenta. But what happens most of the times, this lower edge of the placenta goes behind the fetal presentation part, and we don't see how far it is from internal os. So to be on the safer side, if the placenta is not lower edge of the placenta, in posterior placenta, if it is not seen, it is better to go for TVS, confirm how far it is from the cervical internal os, and then just rule out the low-lying placenta. This figure this can help us to know that the normal uterine segment with posterior placenta. Here is the placenta. We can see this is the serosa. Here is the bladder, and here is the myometrium, and this is the cervix. We can see this is the bladder. We need to have this interface of the bladder for all our scans. Now, if you can see, there is a space between this placenta and the bladder. This is the myometrial clear space that should be seen in all scans. Here also we can see this is the myometrium, and then this is myometrial clear space, and here is the bladder. So all these spaces, myometrial thinning is one of the signs for low-lying placenta or placenta previa we need to be careful about, and that is why we need to remember these figures. We need to have bladder interface. No placenta accreta should be ruled out without visualization of the bladder. Here we can see this is placenta, then this is the retroplacental place. Myometrial vessels we can see, this is the myometrial thickness, and this is serosa, and this is the bladder. So unless we have this picture, our scan is not complete for the evaluation of the placenta. So we should know the bladder mucosa. Is there any invasion in the bladder mucosa? How is this intactness of the serosal layer is must for each scan. Here also we can see this presenting part. Then placenta, retroplacental halo is seen. Then behind that is the myometrial thickness, serosa, and we can see the bladder. Here is the cervix. So this image is complete image for the evaluation of the placenta. So prenatal diagnosis is based on number of different signs which are described. So many signs are there described, but standardized by this European Working Group of Association Abnormally Invasive Placenta. We'll be discussing about these lines. The one is the loss of the clear zone of the placenta. Here we cannot see the retroplacental halo. There is a loss of this retroplacental halo. Then abnormal placental lacunae, bladder wall interruption, myometrial thinning, placental bulge, and focal exophatic mass that we see in the bladder. With color Doppler imaging, we need to use the color Doppler to know the vascularity, where it is, and utrovesical hypervascularity, subplacental hypervascularity. We need to document the bleeding vessels, placental lacunae, feeder vessel if it is there, and we can use the tool of 3D Doppler, and we can document the intraplacental hypervascularity. So this study gives us the standardized signs which can be used for placenta accreta or abnormally invasive placenta. Here we can see this is the bladder. This is bladder and this is placenta. We can see the serosal surface and we can see the equiescent space behind the placenta, which is normal. And this equiescent space, if it is not seen, then we are dealing with a case of placental accreta, or we need to use the other tools for confirmation. Here also we can see, we can use the color Doppler and see the retroplacental blood vessels. Coming to placental legs and placental lacunae. So what is the difference between placental legs and lacunae? Legs are located near the fetal surface or within the placenta. Their shape is usually round and they develop in first trimester. They are not of much clinical significance, but sometimes they can be combined with the presence of lacunae also. But as otherwise, they are of no clinical significance. Whereas placental lacunae, they are located in the placenta. Their shape is irregular, ellipsoid. they develop progressively during second trimester onwards, and they have very high association for pus. Ultrasound appearance, that's why they give like a moth-eaten appearance. The blood flow, if we start the color in this vessels, then they will have very high velocity because they are getting blood supply directly from the radial artery or the arcuate artery. So this is the normal homogeneous placenta. Whereas we can see the irregular, elongated placental lacunae here, whereas these are the small placental legs without any irregularity. So these are again placental lacunae, though this is scary to look, very high flow vessels, tornado vessels will be seen, but as long as placenta is in upper segment and there are no features, we need not worry about these placental legs. So here also we can see the placental legs circular in the substance of the placenta, and we can see that there is a clear placental space. Placenta is in upper segment and myometrium thickness is good. We can see the serosa also. So these placental legs are benign. Coming to next sign is the bladder wall interruption. We can see the smooth bladder wall line, the serosa, was uterovesical peritoneum, and you can see this bladder and the placenta or the uterus. But if this line is not uniform and if it is interrupted, we can see that this type of interruptions in this bladder wall, or sometimes it is myometrium is so thin that there can be a bulge in the bladder itself. So these we can confirm with the help of the color Doppler. Again, we can see that there is placenta is bulging as an exophytic mass in the bladder, whereas we can see the intact serosal line in the bladder and placenta. So definitely these signs are going to help us, but we need to have them together and an overall picture. Not a single line will be very diagnostic for Placenta Accreta syndromes. We can see, when we see color, when we start the color, we can see that there is a flow in this vessel, but these vessels are parallel to the surface of the uterus, whereas these vessels are perpendicular to the surface of the uterus, and they are just becoming the perpendicular to the serosal line. So this is hypervascularity, which is seen in serosal layer of the uterus. Some placenta vascularity also will be seen. We can see the vessels parallel to the uterus surface, but when these vessels are seen as invading the placenta, then we need to be really worried about. Sometimes we can see the breaching vessels on color Doppler. We can use the power Doppler for such cases because these are low velocity flow vessels, and we can see that though this is parallel to the uterine surface, but these vessels are perpendicular, and we can see these breaching vessels on color Doppler. So these myometrial vessels generally will be seen here. Also we can see these myometrial vessels, and these myometrial vessels, if we don't use color, we can say them, confuse them as a placental lacunae. So when we put the color, we can see that their direction, how is the direction in this flow, and we can distinguish them as the myometrial vessels. Apart from that, we need to see the thickness of the myometrium. Here we can see the normal myometrium. Here, lower part, we can see the myometrium, but in the upper part, we can see there is no more any myometrium which is seen. And the placenta is directly invading as if in the bladder wall. So we can use this that sign also. Other sign is interrupted serosa. Again, same. Here we can see the serosa is intact, whereas no serosa, here is no loss of normal serosa. We can just document the signs. Here again is very vascular retroplacental bed, lot of myometrial vessels in all the direction, chaotic flow, which can be very suspicious. Intraplacental hypervascularity we can use with this newer gadgets, and we can document the whole placental vascularity with this. Then this is very good paper which gives us the Delphi consensus in 2023, very recent, which gives us the correct terminology for this definitions for the sonographic signs of pus. When we call them as a placental lacunae, Society for Fetal and Maternal Medicine Task Force was describing this, whereas now Delphi consensus says that these are the terminologies where we can see that the large irregular hypoechoic intraplacental spaces located above the larger feeder vessels, giving the placenta as a moth-eaten appearance, now is called as placental lacunae. The other features like abnormal uteroplacental interface, we can describe them as a loss of clear zone or hypoechoic retroplacental zone. The loss of or irregularity of the normal hypoechoic plane in the uterine wall underneath the placental blade, or the bladder wall interruption, myometry in thickness if it is less than 1 millimeter. These will be described as per the Delphi consensus. Other things are bridging vessels and abnormal uterine contour, placental bulge, as we have discussed, and exophytic masses. Here we can see that ballooning of the uterus containing placenta into the surrounding structures. These are the terminologies which we should uniformly use to know the extent of the invasion and which type of placenta PS we are dealing with. Sometimes there can be we can come across small cystic spaces, and if we turn the color, we can get those scary colors. These are the cervical lakes, which will be seen in cases of placenta previa, especially when they are posterior placenta previa, and when woman is at low risk. When there is no risk of previous, no history of previous cesarean section, we may come across such cervical varicosities, which are the clue for past cases. So there can be sometimes normal variants or pitfalls. We can see such small cystic spaces or vessels in the bladder serosa, and these are normal bladder varicosities. We need not be worried about much. The diagnosis is better in second and third trimester, but the screening should start right from the early pregnancy. This ISWA gives a very good paper about the screening of morbidly adherent placenta in early pregnancy. So where they have shown that they have screened the women at 11 to 13 weeks. Again, they have called them back to confirm that the placenta was low-lying, and if the placenta was low-lying or there was morbidly adherent placenta, as they described, that she was referred for higher centers, and see the frequency of scans they offered for monitoring these patients at 14 weeks, again at 22 weeks, 32 weeks, and later during the cesarean section. So these patients, they will need a regular follow-up to note how much placental invasion is going and how much the other structures are being invaded. So the screening, why there is a rationale for screening the placenta accreta in early pregnancy, because we can know the placental, we know that the blastocyst implants within the endometrial canal, and then placental tissue is typically seen around 10 weeks of gestation at transabdominal, whereas earlier in transvaginal scan, and we can demonstrate the intervillous blood flow by Doppler as early as 11 to 14 week scan, and the placenta is well formed by 40 to 15 weeks. So by NT-scan, we'll be able to look at the placenta very well. The normal placentation process, we know that there is normally placenta, gestational sac will get implanted in the dorsal wall of the uterus, and this is very, very important when we do the first trimester scan to locate the pregnancy, gestational sac. There are various locations that can be seen by ultrasound picked up by early pregnancy scan. We can see here, this is a eccentrically located gestational sac. This is normal gestational sac. Normal gestational sac. Here is this. This is the interstitial pregnancy. We can see here the interstitial line sign, and here we can see the gestational sac is located in the C-section niche or the isthmocele, which is nothing but the CSP, cesarean scar pregnancy. Early diagnosis is important because if we see a patient, this patient has come at 7 weeks and the sac is here and extending to this. I don't know if the sac was located here and now it has started growing towards fundus, or right from the first, right from the implantation time, it was there here and now it is growing here. So as early as possible, we should be able to diagnose the site of the gestational sac, because we need to prognosticate the CVS, how it will progress to pass. So CSP, as Timotesh says, that it's a baby pass. So we should never ignore the location of pregnancy. We can see here this CSP, cesarean scar pregnancy in the uterine niche, cesarean section scar niche. We can divide this uterus into 4 quadrants and then see where is the gestational sac. The low implanted gestational sacs, we need to monitor them and we need to be vigilant to know that there is no placenta, low-lying placenta or placenta accreta syndromes in this patient. So these isthmocele cases, we should be very careful because these are the isthmocele cases where there is a chance of future pregnancy location, and we need to diagnose these pregnancies as early as possible. So this was a case, a doctor came with previous history of cesarean section, and she was wise enough to come on the day when she missed the period, 30 to 33 days. And we can see this is small gestational sac of 2 to 3 millimeters at the level of the cesarean section scar. And she was lucky enough to get it terminated early, failing which it could have proceeded to CSP or pass in future. So the counseling in fetal medicine is evidence-based answers we need to give, and which is very important. And if we divide this line, serosal line, bladder line, we need to see where are these vessels invading. Is it in the lower pole or is it in the upper pole of the bladder? And that is how our counseling will start. The upper posterior bladder wall is labeled as S1 here, and the lower one is referred to as the S2. And so this is going to counsel the patient and have the multidisciplinary approach. MRI is a very good tool, but not needed every time when the sonographer is damn sure of the diagnosis. MRI is especially helpful when the evaluation of uteroplacental interface is difficult. For example, if the placenta is posterior, the woman is obese and we are not able to diagnose this placenta accreta syndrome by ultrasound. There are various signs described for MRI. I'll not go into details, but these are like the intraplacental dark bands which will be seen, or utero and placental bulge which will be seen, and then myometrial thinning which can be seen here as this line, or the bladder invasion or bladder interruption, or the focal exophytic growth that can be utilized. This also I have one paper where it has described this very good paper. This describes 3-step approach for screening these patients with in poor resource settings. What it says is they assess the risk of placenta accreta, like pre-test probability. If it is anterior low lying, less than 2 centimeters from the os or placenta previa, previous C-section delivery, then or history of uterine surgery, that is the awareness. Second is, remember that it is a spectrum, and each spectrum will have different ultrasound signs representing the anatomical features unique to that case. And third is, consider the clinical relevance. All these signs we need to consider. What are the signs? And then we need to map or decide the topography of the placenta for the better operative management. To conclude, placenta prenatal ultrasound may help predict the depth and topography of the placental invasion. Antenatal diagnosis of placenta accreta spectrum can reduce the hemorrhagic morbidity, and sonographic markers of past disorders can be present in first trimester. So never forget baby pass, that is CSP. So we need to be committed, we need to confirm, we need to learn, and we need to take into consideration placenta as a very vital organ, and let's not overlook the placenta for better obstetric management. Thank you so much.
Thank you so much, Megha Mad. That was a wonderful presentation with all the pictorial representation. Your slides reflect not only your expertise, but also the machine that you're using. Must be a high-end machine, of course. And Madam, all your points are well taken, Madam. You emphasized that a simple ultrasound can diagnose adherent placenta, and when required, you can use the color and the Doppler to diagnose invasion. And also your slide on the cesarean scar pregnancy, which can later turn into placenta accreta spectrum. That was really insightful, Madam. So we will remember that when we see a pregnancy that is low-lying close to the scar, one should have a red flag, and we should work on it. And also the take-home message in the low resource settings, how one should be careful and be always receptive to all the findings that are there. So very well rendered, Madam. Thank you so much for the presentation once again.
Thank you so much once again, Asha ma'am. My pranams to you.
Thank you, Dr. Megha. You really did a wonderful job. You're a obstetrician, so you also covered the part that is actually relevant to us gynecologists. Thank you so much for that. Thank you. If you would please stop sharing, then I would.
Sure.
So it's always this wrong one that gets shared. Can you see the slide?
Yes, ma'am, we can see it, but it has to be made full screen, ma'am.
Wait.
Dr. Padmavathi hasn't logged in, ma'am, so we'll request Dr. Lakshmi ma'am to chair the second session too.
Yeah, sure. We'll proceed with the next topic, that is conservative surgery for PAS. So I have managed 5 cases of placenta accreta and percreta, but all the while I had to go for cesarean hysterectomy, and almost each patient received 5 units of blood. Luckily, all of them I could save. So it is very interesting to go to the next topic and learn about the conservative surgeries, though it was a bit scary because our worry is secondary PPH and sepsis. So I invite Dr. Mahesh Gupta sir to render his delivery on, a lecture on conservative surgery. So Dr. Mahesh Gupta sir, he is a recipient of 2 gold medals from Gujarat University. It is a pleasure to introduce him. He is also a recipient of Indian Health Icon Award of Times. He developed, patented and published techniques to control PPH. He is having American patent of suture material used for cesarean section and PPH. He is running a 50-bedded multi-specialty hospital at Ahmedabad. And he is also the president of Ahmedabad Obs and Gynec Society 2013. I welcome Dr. Mahesh Gupta sir to start the lecture. Thank you, sir.
Thank you, ma'am, for kind word. Am I audible very well?
Yes, sir, you are.
Yeah. May I share my screen now?
Yes, sir. Please go ahead.
My screen is visible?
Yes, sir.
Yeah. Is it visible?
Yes, sir.
Yeah. So here I am just going to show you my techniques to conserve the uterus in cases of placenta accreta spectrum. So in placenta accreta, it doesn't always mean that it is a previa accreta. It may be in the upper segment, it may be in the lower segment. If it is in the upper segment, it may be a partial or focal, or it may be a complete. Or in lower segment, it is a previa accreta, it may be a partial or it may be a complete. So since last, I think 7-8 years now, we are doing these conservative surgeries. Initially, when we were getting the reference from this IVF referral, we used to do follow the FIGO and WHO protocol, and we used to do a ureteric stenting in all cases, and we were putting the vertical incision and on skin as well as on uterus, and we were going for obstetric hysterectomy. Now, after doing some 7-8 cases, when we examined the specimen in the operation theater, in all the cases we were successful to detach the placenta from the specimen, and then we stop all this thing, and we have developed our own technique, and that I will show you how the physiology of this technique will be helpful and how the anatomy is also helpful. So in the upper segment, how the upper segment placenta accreta, focal placenta accreta will be there. So in upper segment, if you find a case like this, there is a gross dimpling or gross concavity on the one side, and this is called a focal accreta, and this accreta is going to bleed. And here you need to have a conservative surgeries. So in upper segment, today is not a topic, so I'll not discuss how we can doing the upper segment or atonic PPH surgery. Now this is a case of a total fundal accreta. So there is hardly any space between the placenta and the myometrium. You can see this. This is a total fundal accreta. So here, this is, I think, before 8-10 years. So at that time, we used to do obstetric hysterectomy in such cases where there is a total plastered placenta in the upper segment. This was IVF conceived case. Now, after developing some technique, how we perform now, that I will show you. This is a case of a total fundal accreta. IVF conceived 33 years of age of the patient, and how we proceed that I will show you with the video. So this after delivery of the fetus, and the uterus is to be exteriorized. In accreta spectrum, we never touch the placenta, we never remove the placenta. So now this is again a total fundal accreta. You can see the placenta is not detached easily, and you can appreciate the thinness of the myometrium. So myometrium is very thin. So there I am separating the placenta with a finger, and this is a accreta. This is not a percreta. In percreta, it is very difficult. In most of the cases, that it is a accreta only adhesions. 75% cases are accreta, 10 to 15% cases are increta, and while only 5-7% cases are percreta. So we are not doing the conservative surgeries in all the cases, but our conservation rate is 80 to 85%. So in many times we have to do the obstetric hysterectomy. So it is not a science that gives you 100% anything. But we can easily conserve this uterus also. So once you see this, you can believe this. This is the upper segment placenta accreta, total accreta. So we'll go for a systematic devascularization of the upper segment. And then we will go for a compression suture, and the bleeding will stop. This case was done before almost 5 or 6 months. And after that, patient got a period and the endometrium is normal. After completing the surgery, we generally counsel the patient for Asherman syndrome or a secondary amenorrhea. We always counsel the patient for that. And we conserve the uterus. But most of the cases, there is no Asherman syndrome or there is no any endometrial adhesion. So now placenta is separated. So now we are starting with the upper segment devascularization. So we are now targeting the ascending branch of the uterine artery. Because the uterus is supplied from the lateral side in a normally placed placenta. So here we are targeting a lateral devascularization of the uterus. While in case of the previa, how it differs, that I will show you in some more video. So basically we are doing a systematic devascularization of the uterus by taking the uterine supply, only uterine supply. So here we don't need to jump to the internal iliac. We don't need to jump to the common iliac. We don't need to jump to the aorta also in such cases. So this is a right side of the ascending branch of the uterine artery I am taking. And here all the cases, we generally put a 600 microgram of the misoprostol per rectally preoperatively. So we have found out from the net that even a misoprostol also cause a thrombosis in the myometrial vessel. Now we are targeting a common uterine trunk by taking a low uterine, and with the 50 mm round body needle with a single thrust from anterior to posterior, posterior to anterior. So we are taking now a full uterine bunch. It will take care of the full uterine. While upper segment uterine artery is taken to just cut down the anastomotic channels between ovarian as well as the uterine. And after taking these only 4 sutures, you will see that uterus will become totally devascular. So both the side, right and left, uterine artery taken. Now 2 more full thickness myometrial suture anteriorly. This is a full thickness. Needle is going to the endometrium and coming out from the endometrium. And basically the placental insertion was on the anterior uterine wall. So I am targeting the anterior myometrium. If it would have been a posterior uterine wall adhesion, then I would have targeted the posterior myometrial wall. So now after taking this, the uterus is totally now blood free. It becomes a devascular. Now we will place just with the 2-number catgut. That is a special suture is also available with the 2-number catgut. With the straight needle is also available in the market. Now with the name of Comoc MG, that is my suture, we can easily now compress the uterus. So this is just, I am showing the upper segment accreta, how uterus can be conserved. So this is a simple Heyman suture is taken with a 2-number catgut. So primary patient, total accreta and uterus is preserved. Now we are going for a placenta previa accreta spectrum. Here for youngsters or young gynecologists, I suggest how we can go for a temporary tamponade. How we can, if accidentally some gynecologist will held up in the operation theater taking a placenta accreta case, and if there is a bleeding, then how temporarily we can arrest that bleeding and we can call for the help or we can arrange for the blood. So I will first discuss a temporary tamponade, and then we will go for a definitive tamponade, how we can go for a definitive devascularization of the uterus, and that will lead to the uterine conservation. Because the obstetric hysterectomy in placenta accreta spectrum is also a difficult most of the time. And it is my thought that we should not enter in the operation theater with the prefixed mind that we will go for obstetric hysterectomy prophylactically. Because when it comes to atonic PPH, the most of the association and most of the guidelines, they never support that you should go prophylactic management of atonic PPH. That is again a big question. But those association supports the prophylactic obstetric hysterectomy in just placenta accreta diagnosed case. So that is a very contradiction that is very difficult to understand. If you allow a temporary prophylactic obstetric hysterectomy in placenta accreta case, then why don't you allow a prophylactic kind of a surgery in a high risk cases which can bleed post-operatively as a atonic PPH? That also should be allowed. So here we will discuss a temporary tamponade. So in temporary tamponade, what generally I advise and what we do after the delivery of the fetus, the placenta should not be detached. Placenta should be remain there. And this was a previous 2 cesarean case under spinal anesthesia. Just we are making a small rent with the finger and cautery in the broad ligament on one side, and on another side also with the cautery we are making a rent. So we are making another rent on another side. Now you just tie this Foley tourniquet, Foley's catheter, and apply as a tourniquet. The bleeding, all bleeding will stop. There won't be much bleeding then, because this bleeding is an arteriovenous channel. It is not an arterial channel purely. So this bleeding will stop. Then we can proceed for either obstetric hysterectomy or we can proceed for conservation of the uterus, how we can do that. So this is one technique where anybody can do in the operation theater when held up with the placenta accreta cases. Just put a Foley tourniquet and bleeding will stop, and anesthetist will be relaxed. And second thing, I have this published in the international journal and international conference also in 2015, that we advocate a use of Satinsky urological clamp. These are the very big urological clamp used for nephrectomy. Just make a small rent in the broad ligament on lateral side and pass a 4-number size of Satinsky clamp. So is the size and shape of this clamp is so nice that it can accommodate in the pelvis and it will accommodate the whole lower segment. And it has almost 7 catch. If you use a first 3 catch, then there won't be any tissue damage. And 2 small size Satinsky clamp you can put on the infundibulopelvic ligament like this, and then you can call for the help, and you can take a decision to arrange a blood, and patient will not bleed till that time. So these are the 2 techniques for a temporary tamponade in case of lower segment bleed, one can use without any fear. Now, we are going for a placenta accreta or placenta increta cases, that is lower segment, and then how we conserve the uterus, that I'll show you. So these are the initial days. We were going for a radical approach in all the cases like this, but in the post-operative specimen, these all placentas were easily be removed from the uterus, can be easily separated from the uterus. So then we stopped doing this uterine hysterectomy in all the cases. So now we have developed one more technique to control this placenta accreta bleed. Now here, before I am discussing this, I am showing this technique. Just I'll tell you, in placenta accreta, there is a gross remodeling of the pelvic vasculature. In fundally placed placenta, there is only lateral supply from the uterus, that is from the majority from the uterine artery. But in case of placenta previa, there is a lateral supply from the uterus, as well as there is a vertical supply from the central anastomotic channel between the anterior division branches of the internal iliac and branches of the posterior division of the internal iliac and branches of the external iliac and branches of the femoral. So there is a gross pelvic vasculature remodeling. So if you will cut down the lateral blood supply, the bleeding will not stop. You have to now cut down the vertical supply also. This is a basic physiological understanding. That unless you will cut down the central supply towards the lower segment, the bleeding will not stop. So that's why internal iliac artery will not be helpful in the lower segment bleeding. That I'll show you a good picture for that. Now, how we are cutting the central vertical supply, that I'll show you with this animation. After separation of the placenta, after taking both the uterine artery, after separation of the placenta, we dissect out the bladder as low as possible. And this, with the special straight needle suture, we pass a straight needle from front to back like this on one side, like this. In the parallel, the other needle pass at the same level. This is either at the isthmus level, lower isthmus level, or at the cervical level. So cervical dilator is kept to keep the cervix patent. Now this simple suture is taken on one side. The same thing is to be done on another side. So this will take care of the vertical central supply to the lower segment like this. And all bleeding will stop. So this is a cervico-isthmic suture, and by putting a dilator, we are putting a dilator. Some may using artery forceps also, but if you put a large bore dilator, then the cervix will remain open. So this is a cervico-isthmic technique. These are all these in previous my learned speaker shown all the pictures, sonography pictures. So I'll not go into detail. Now I'll show you how we are doing the placenta accreta in uterine conservation, and how the common cesarean section differs from this cesarean section, that I'll show you. So I have two videos to show. In one, we are going for a segmental resection of the lower segment, and one we are not going for segmental resection, and we are putting a cervico-isthmic suture. So now, so these all cases are under the regional anesthesia. All cases are with the financial incision, previous financial incision. We are putting a financial incision. And all cases given 1 gram of the tranexamic acid preoperatively. Otherwise, nothing special is given. Now, this sheath incision is called a St. George skin incision, sheath incision, because my skin incision was here, but we are going almost 1.5 to 2 inch above to open the skin. So that is called a rectus sheath incision. It devised by the St. George. So this is a St. George rectus sheath incision. The rectus sheath is opened very higher level. So I can easily reach up to the fundus of the uterus in a transverse incision. And if accidentally, if I find a plastered abdomen, because these are usually a multiple cesarean cases, so we find a plastered abdomen in many cases. So if we go high up, then we can easily enter to the abdominal cavity. And if there are plaster kind of bands, then we use this bipolar shearer. It will give you a bloodless field. If you use a monopolar current in such cases, you may get a bleeding more. But this is a bipolar high current, and this bipolar shearer it will coagulate and cut, so give you absolutely a bloodless field. So this bipolar shearer, or you can use a ligashore, or else you can use a NSIL also in placenta accreta cases. Now, after separating the band, just we put an incision again on the transverse, and this is little high transverse, upper segment of the almost the placenta, and then fetus is removed. And after removal of the fetus, generally we never pull the placenta, we never touch the placenta. This how the cesarean differs. In routine cesarean section, we take out the placenta, but here we are not taking the placenta. Placenta is still inside. Now we are targeting a bladder separation till the cervix, like this. This was the case of previous one cesarean, yes, probably one cesarean section, and diagnosed as a placenta accreta. So here we are doing a sharp dissection with cautery. We don't push a bladder, a peritoneum, otherwise there will be a bleeding from the uterine wall, because uterine wall is not supported very well. Because of the developing placenta, the uterine wall has been eaten up. So if we push with the finger or with the gauze, then uterine wall will be tear off. So this is a low uterine artery taken on both the sides. So by taking this both the uterine artery on lower side, we are cutting down almost 70-80% of the blood supply to the placenta. Now we are targeting a central supply. So posteriorly at the full thickness myometrium, we may take one or two suture at the level of either cervix or at the level of upper uterine part above the uterosacral ligament. Now we target to separate the placenta, because now we have made the uterus devascular. So this is a systematic devascularization. So now we are targeting a placental separation. And once you take the uterine artery on both the side, and once you take a posterior sutures, there won't be much bleeding now. Now I am targeting, after separating little placenta, I am targeting now the upper uterine branch, like this. So two vascular suture on right side and two vascular suture on left side. Almost one or two vascular suture on the posterior full thickness myometrium and one or two full thickness suture on the anterior myometrium. And if needed, there is a cervicoisthmic suture. Your uterus will become practically devascular, and there won't be any bleeding. So now again we are targeting a placenta, placental removal. And in this process, if there is a little bit of the placenta remain in the lower segment, there won't be any much problem. This placenta is now, it was a accreta, it was removed now. Now after separation of the placenta, we examine the lower segment, and if still there is a bleeding, then we go for the animation video which I had shown you of a cervicoisthmic suture. We are putting a cervical dilator like this, and then we'll go a cervicoisthmic suture. And cervicoisthmic sutures, they are the master suture. It will stop all vertical bleeding. Like this, we are putting a cervicoisthmic suture. The straight needle is going from anterior to posterior, medially just touching the cervical dilator. And these are again the Comoc MG suture has been used, which is available in the market. One side there is a round body needle, and one side there is a straight needle. This round body needle again pass either in the broad ligament from avascular area, or you can pass from the cervix also. And then it is to be take a suture like this. And one more suture on right side. So only this much suture. You can appreciate that we are not taking much gauze or a mop to clean the field. Then uterus can be conserved easily. And we remove the dilator. And additionally, we take like this, the full thickness interior wall myometrial suture. So we take a 50 mm needle always. Now this absolutely it becomes a bloodless field. And generally, if there is a very thinned out the myometrium anterior wall, then we refresh or we freshen up the myometrial wall. So this is the one technique I had shown you. Now we'll go for another technique where we are showing a Increta case and where we are going for a segmental resection. This was again a previous to cesarean section under the regional anesthesia, that is a bupivacaine and spinal anesthesia, and placenta Increta diagnosed with the two fetal medicine specialists and shown the bladder invasion. Also this case here again the same thing we are doing. We are cutting the sheath little at the higher level. We are using a coagulation current of the cautery. We are not using a cutting current because the high coagulation current will give me a very good coagulation as well as cutting also. So this is not a simple cutting current. This is a coagulation current. So all my settings on the cautery is a coagulation very high, maybe 80, maybe 100. Now here, this is the cesarean of the common is different from this placenta accreta spectrum. Here we are not in a hurry to take out the fetus. We are in just giving a ample time to separate the bladder from the uterus, because the bladder separation is a 50% success. And like this, we are using a cautery current to separate the bladder, so it will get a bloodless field. So field will remain very clear and in bloodless. And on left side, if you'll observe, the placenta has been came out from the uterine wall. See, here the placenta has, you can see the placenta here, and placenta has come out from the lower uterine wall here on the left side. As the procedure will go on, you will see the uterine wall. Now this placenta is coming out. You can see this placenta has come out from the uterine wall now. So I'm pressing with the gauze, and still I'm more concentrating on the bladder. Now I put an incision over the uterus. Now the uterus is exteriorized. Let the placenta is to be there. Don't disturb the placenta. And again, we are targeting a bladder. Here the placenta is almost out from the uterine wall, and we are targeting again the bladder. So bladder is separated. So most of the time the bladder is separated to the previous two scar. Once you go below, there won't be, you will get a good plane. Now the uterine artery taken on the left side like this. So left side of the major blood supply is being taken. Now just I am going for an upper part of the uterine like this. As I had shown you, the two vascular ligature on left side, now 2 vascular ligature on right side. Again, we are separating the bladder from the broad ligament because it is a virgin area. You can easily separate the peritoneum as you go laterally because it is usually a virgin area. Then you go in the center. So once you go laterally, then you come in the center to separate the bladder like this. And then you go below the placental attachment and take a uterine artery like this. So here I'm at present concentrating on the lateral devascularization of the uterus. So laterally the uterus has been now become almost devascular, taking the uterine vessels. Then I'll target a central vertical supply after taking this lateral supply. Now lateral supply is taken care of. Now I'm taking care of the vertical supply. I'm putting two transverse suture on the posterior myometrial wall. That is the full thickness of the myometrial wall taken at the posteriorly to take care of the vertical supply from the posterior side also and now I'm targeting on the uterine wall and the placenta. Now here, after doing this much devascularization, I am doing a segmental resection of the myometrium with the placenta like this. So we are not separating the placenta from that uterine wall. We remove the uterine wall along with that placenta. So there won't be much bleeding. You can see this. One more additional safety suture is taken. Now again, we are targeting a bladder separation from the lower uterine segment. And then we suture the uterus in a vertical, in an interrupted manner. We are not going for a continuous non-locking suture. Just I'll show you that how we suture the uterus. And this cesarean is taking the same time as a routine cesarean section. Like this, we are taking up parallel sutures, interrupted parallel sutures. So all the blood vessels which is going towards the wall, cut edge will be taken care of. Like this, the transverse suture which is parallel to the uterine, cut edge of the uterine wall is taken like this. So just my take is that not every case you need to go for obstetric hysterectomy, and your decision should not be guided or misguided by the sonologist. You now take your decision and gradually you can see that in which and how many cases you can conserve the uterus and how many cases you really require obstetric hysterectomy. Because most of the time I have seen in my practice, because I am getting most of the referral of the Gujarat Accreta cases to me. So most of the time everybody is speaking about the Accreta, but hardly I see the Accreta. And most of the time I am getting the Accreta only, or it is a Increta most of the time, not Accreta. Accreta in my life I have seen only 2 or 3 cases of the real Accreta. Otherwise, this is a real Accreta. There may be a hemoperitoneum, there may be a hematuria, kind of things are there. If it is not there, then and patient is vitally stable, hemodynamically stable, then it is most of the time it is Accreta, or at the most it is Increta, not Accreta. And generally we keep 2 bottle blood ready in all the cases. This
So,
that's how we complete our
yeah.
surgery.
Thank you so much, sir. That was a very wonderful presentation from you, sir. Many valid points were shared here.
Yeah, this is a important thing I'm showing you.
Yes, sir.
Why internal iliac artery ligation? See, ligation or occlusion of the internal iliac arteries for the treatment of placenta accreta spectrum. Why is this technique still performed? That was a paper, and they had shown this picture. This is a placenta, this is a bladder, and if you ligate the anterior division of the internal iliac artery, then only obliterated umbilical artery will be totally thrombosed. Otherwise, there is anastomotic channels between the posterior division and anterior division, so it will not work. And just if you give me a minute, I'll show you the real interesting Accreta case that we have done just before 3 days. See, this is a real Accreta case. You can see the placenta here. Hello?
So we cannot
Sir,
see.
can't see it.
We cannot see, sir.
Huh?
We cannot see your picture.
Sorry. Because this is hyperlink, so you may not see this. Sorry. Because just before 3 days we did this. This is a very interesting case, but this is hyperlink, so that's why you will not see it. Anyway, so that was my presentation about the uterine conservation in placenta accreta spectrum.
Sir, hyperlink दिखा दीजिए ना.
That is a very
Click करके
interesting
दिखा
case.
दीजिए.
Yeah,
दिखा
just a
दीजिए
minute.
ना. We are there.
Yeah.
We'll wait.
Yes, sir.
Yeah. Because I have not edited. You can see this now?
No, sir, not it.
Okay. Then what I have to do, just a minute. I'm stop sharing first. Then I'm again share. I think now you can see.
Not it.
Yes, sir. Now we are seeing.
Yeah, you can see this now?
Yeah, we can see. We can see, sir.
Yeah, now I'll show you. This is a rarest of the rare case I'm showing you.
Thank you so
Rarest
much.
of the rare. Huh? Yeah, see, and this is a real Accreta case. And this is a totally misdiagnosed or undiagnosed case. I'll show you. This was an undiagnosed case. You can see the
Yes.
placenta here. You can see?
Yes, sir. Yes, sir.
Yes. I had a goosebump after seeing this. That what to do now? And patient blood group was AB negative.
Oh,
Primary
scary.
undiagnosed. Now still the let you see the movie. It is because it is not edited. Just before 3 days I did it at someone's place, someone nursing home. As soon as I put a Doyne's retractor, there was a bleeding. So I pushed that bleeding with my finger and I was searching a bladder. Where is the bladder? See, there is a bleeding everywhere.
Everywhere.
So I thought that this must be a bladder. Let me separate it. So I started separating the bladder, but I was not successful. There was a bleeding from everywhere. So I'm pushing that bleeding with my finger. You can see the bleeding.
Yes, sir.
Yeah. So then I thought, oh, let me first remove the fetus. See, there's a bleeding everywhere.
Everywhere.
Then I put an incision like this.
Blood everywhere.
Then I take out the fetus, live fetus, 2.4 kg. And most of the time, these are the bridge presentation or oblique presentation. And the story changed now.
Hmm.
Once I take out the uterus, you see, what is it? This is uterus.
Oh,
This is uterus.
it's
Can you see this? This is uterus.
so thinned out. It's like paper.
So I was worried that now what to do.
This paper
And I had examined the uterus panoramically from anterior, posterior,
Hmm.
and then I find it is a non-communicating
Rudimentary horn.
rudimentary horn pregnancy.
Oh, anticlimax, sir, actually.
Yes.
I
So
expected.
uterus is here.
Uterus is here, separate.
Uterus is here. So it was totally based on
Based on
five sonography. This is a small uterus here.
Yes,
This is a
yes.
small uterus here.
Hmm.
It's a non-communicating rudimentary horn giving a live pregnancy with
2 kg baby.
and accreta.
Yeah.
This is probably the world in the rarest of the rare cases.
Rarest case.
And then I applied the clamps all over, and then I started the resecting this rudimentary horn.
You are publishing this, sir?
Yes, I will publish. This is just 3 days back.
3 days back.
Yeah, just 3 days back. You see the rudimentary horn?
Yes, sir.
Yes.
So
Excellent, sir.
yeah. So thank you so much, Dr. Asha, for allowing me. And
Thank you so much, sir. That was really, I'm at a loss for words, sir.
yeah, because in my operation theater and or whenever I go, I will take away with my all recording system. So all the cases are recorded everywhere.
That is
So I have a huge collection of all the interesting cases of the obstetrics cases like this.
yes. That is commendable, sir. Sir, I have some few doubts, sir. That
Yeah, sure.
that placenta accreta, which you had shown us the previous video,
Yeah.
when you separated the bladder, was there some amount of placenta that went with the bladder?
Yes.
Uh,
No. Placenta doesn't enter in the bladder. But in
didn't.
sonography, what happened in 2D sonography when the waves are coming from the anterior to posterior, the blood vessels it is like if you feel that blood vessels are in the bladder,
Oh,
but not it is like that.
it is
So
not.
here the bladder separation is very important. So we give a ample time for bladder separation. We are not putting an incision on the uterus because in before 15 days, last Tuesday,
Yes, sir.
there was a on-table death of accreta.
Oh,
When I reached there was a torrential bleed everywhere. And when I reached there, just I started the surgery, the first cardiac arrest occurred, the DC shock given. And during my 15-minute surgery, because I remove everything, the 4 times the DC shock given.
Yes, sir.
4 times cardiac arrest and patient die on table. This is just 13 days back.
It's always timely seeking for help also is important, and we have to anticipate. So most of the time accreta, it doesn't give us much time actually. Within 15-20 minutes, it is blood everywhere and patient suddenly succumbs.
So don't put a uterine incision straight away.
Yes, sir.
First separate the bladder till cervix. If it will take 15 minutes, no issue. If it will take 20 minutes, no issue. It will take 30 minutes, no issue.
Yes.
Because if you separate the bladder by giving ample time and there is a proper bladder separation without bleeding and without injuring the bladder, then your post-delivery time will be very less.
Very less.
Once you deliver the fetus by putting an incision, then the bladder separation will become messy. Because blood is coming from the uterus also, that will spoil the field, will not find a proper plane. And here, the most of the time we are pushing with the finger, we are pushing with the gauze. Don't do that, because the uterine wall doesn't have enough strength to withstand your push.
Yes, sir.
Because the uterine wall has been eaten up by the placenta, and it has become very thin. So don't push with the finger, don't push with the gauze. Otherwise, we will enter in the straight away in the uterus. Then there will be difficulty for the separation. So give enough time with the patient's mind, because there is no bleeding. You are not open the uterus, so there is no bleeding.
There is no bleeding.
Time.
Yes, sir. Yes.
So there are more questions from the panelists. So
Yes.
requesting all faculty, if you would put on your videos and ask your question directly to sir while the surgery is being demonstrated. Monika Didi?
Sir, I want to know, you have removed the rudimentary horn, is it?
Yes, yes, I'm removing.
You're removing the rudimentary horn. And what about
Yes,
the
yes.
uterus? How did you manage the main uterus?
There's nothing to manage. Uterus is good. She may
But it's
conceive.
very thin-walled. It must be bleeding profusely. What about the placenta and all?
I have removed the N mass.
The uterus also. You did the hysterectomy in this case?
No, uterus is
Rudimentary horn.
spared. Uterus is spared here.
Okay.
Uterus is spared here. See, this is uterus. I'm sparing the uterus. Generally, when we are doing obstetric hysterectomy, we are cutting and ligating on the this lateral side. Here, I'm cutting and ligating on a medial side. This is a difference. Can you follow my technical point? When we are putting in obstetric in any hysterectomy, we are ligating the ligature on a lateral side.
Yeah.
Here I have to conserve the uterus, so I am ligating on a medial side,
Okay.
not lateral side. This I am separating a bladder here. You can see this?
Yeah.
Yeah. So I'm separating a bladder. And then I'll take out the whole unicorn rudimentary horn uterus with placenta.
It is a rudimentary horn pregnancy with an adherent placenta. So the horn is
Yes.
removed along with the placenta by
Placenta.
separating the bladder
Yes.
much prior to the delivery of the placenta. That is.
Yes.
So excellent, sir. Wonderful techniques you have demonstrated today, especially that vertical isthmo
Yes.
cervical stitch which you have demonstrated. I think we should start using it. And
that is a master suture for any lower segment bleed.
yes, sir.
Not only in accreta percreta, but in any placenta previa also. Many times you will feel that the valley will be filled with the blood. Again, you suck it out. Again, the lower segment, the valley will be full of blood. In those cases, either you take both the uterine artery as low as possible. We many times go at the origin of the uterine artery below below the ureter. Yeah,
Yes.
we are going so lateral sometime in placenta accreta, and then bleeding will stop.
Yes.
So this just I'm discussing with you just to remove the thought blocks and mind blocks which is there since years. Our bosses have put that mind block to our mind. That don't touch the placenta, don't touch the placenta, do this. But you can do now.
Yes. After appropriate devascularization, we can.
Yes. It is a simple thing. You have to devascularize the uterus. That's all.
I have to get the Stansky clamp also, sir, after your presentation.
Satinsky clamp, yes.
Thank you so much, sir. Wonderful presentation.
Thank you, Dr. Asha Ji.
Sir, thank you so much for being here. I'm really honored because at Searchlite, we try to get stalwarts who actually add a lot of value to the webinar. And, Dr. Megha is still here. She's a fetal medicine person and she's still mesmerized by this. So I'm Very, very thankful to you, sir. I saw you once, and since then I have wanted you. I hope it has been a good takeaway for everyone, all
Yes,
our
ma'am.
faculty, and also the delegates.
Thank you
And
so
So,
much for giving
And
us.
you never guided by the sonography report or MRI report. You just do surgery, then you correlate. Because I was in fetal medicine from 1988. From 1988 to 2004, I was into fetal medicine. I had attended the Kipros workshop in Portugal, fetal medicine foundation workshop for 7 days. I had attended the ISOG in Australia. And I was first for this NT certification from India. I was the first in 2002.
Okay.
So
So
I
nice,
used
sir.
to,
So nice.
when our referral came to me, I just asked them to send me a scan image with partial full bladder, transabdominal scan image with partial full bladder. Then I will take a call.
so thank you, sir. Thank you. We
Thank
have
you.
a panel to run as well, and thank you so much. After all this, after the ultrasound and also this magnificent surgery, I think is going to be just fun having that panel, which we will just see what we will do in those situations. Thank you, Dr. Lakshmi, for taking up both the chairpersonships. Thank you so much.
Thank you
If
so
you
much.
would,
It was a pleasure
I mean-
actually to be a part of this. Thank you so much.
thank you. Thank you, Mahesh sir.
Thank you.
Very,
Thank
very honored. And any other unique surgery, sir, we would really love to have you again.
I had all the surgeries which are mentioned in the textbook. May it be gynec or may it be obstetric. I have all the recording.
Digital library.
Yeah, everything in my.
Because we would do one more on, conservative surgery for prolapse, where I will have Dr. Hara sir actually explain the classification again. And then if you would demonstrate the surgeries, we would love to do that again.
Nice.
But I'm more into obstetrics.
I know that, sir. But you said anything in the obstetric gynae book.
I have all NDBH, I have all prolapse surgery, I have all this CPT repair, I have all this rare surgery like sphincteroplasty.
Many are living obstetrics, sir, now. So your surgeries are encouraging for them.
Thank you.
Thank you so much.
Thank you, sir. Thank you so much. So now I request all my panelists. Thank you, Dr. Megha. Thank you, Mahesh sir. We would be gratified if you could stay over. But if you are busy, then namaskar.
Thank you.
So this is my Gurudev. And I think what Mahesh sir just said, whatever you do, do it excellently. So excellence in work, excellence in interhuman relations, excellence when none is watching you. Such excellence will only come when you are not enslaved and experience true freedom and dignity. He is from my Guru. I convey my pranams to him and we start the panel.
I request the participants to please mute your speaker, please.
Your voice is getting echoed. Have you logged in from 2 devices?
No.
Okay.
Somebody else has logged in from 2 devices. So we are going to have panel on past disorders. And I've been introduced. Here are my respected panelists. Dr. Nalini Katta. She's a consultant obstetrician and lab surgeon at Ravi Nursing Home, Malkipuram. She has 14 years of experience. She's been with us many times before in Searchlite.
Ma'am, I request Dr. Monika Agrawal to please log in from one phone, ma'am. I think that's the reason for the echo. Dr. Monika, if you could just log out from one phone, it would be very helpful.
Should I log out?
No, Didi. Please, only from one instrument.
Okay, okay.
Only one instrument. We have Dr. Nirupama Palakodeti, MS FMAS, Senior Consultant Gynecologist at Sri Gautami Nursing Home, Bhimavaram. She's ex-associate professor, Geetam Medical College. She's also one person who's been with us before. Dr. Vijaya D has joined me for the first time. She's an obstetrician, gynecologist, and lab surgeon at Bhimavaram Hospital. We have Dr. A. Sushma. She is passionate about women's health, ambitious gynecologist and obstetrician, aims to offer comprehensive women's healthcare services. She is at Sri Ahobila Women's Healthcare, and she has a diploma in reproductive medicine, specializes in high-risk obstetrics, vaginal surgeries, gynec surgeries and minimally invasive surgeries, fertility treatments, and gynec ultrasound. We have Dr. Narasavani S. She has been with us before. Thank you, ma'am, for being again with us. She is the Vice President of Bhimavaram Society.
Good evening, ma'am.
Consultant SVR Maternity Hospital, Bhimavaram, has 24 years of experience, and her areas of interest are high-risk pregnancy, PIH, and ectopic pregnancy. We have Dr. Monika Agrawal, ma'am. She's a gynecologist from Raipur. She is my senior and has been kind enough to join. She's MBBS, MD, FMA. She hasn't written many things here, but she's a very, very active academician, does IVF and all kinds of obstetrics and gynec surgeries. So welcome, Monika Didi.
Thank you.
Now, requesting all the panelists, I haven't allotted any case to anyone. So requesting you put on your videos and let us take the cases one by one. So this is a 28-year-old primey. As sir has said, it was a primey with no prior cesarean section or uterine surgeries. She presents at 36 weeks with painless vaginal bleeding. Ultrasound suggests placenta accreta without significant invasion. So how common is placenta accreta in a primey? And what are the risk factors?
Good evening, ma'am.
Yes,
Shall I answer?
Yes, please go ahead.
Usually, this placenta accreta in primary is the chances are very less, unless there is any surgical intervention like myomectomy or any surgical abortion history. But in this case, history doesn't show any like surgical interventions previously. So accreta chances are very less. And if there is any chance of placenta previa, even with some scar on the uterus, we can suspect accreta sometimes. The chances are increasing only with the uterus scar is there, and sometimes due to cesareans and myomectomy.
No, but if there is nothing there, what risk factor should be considered? It could be a placenta previa, right? It's a painless vaginal bleeding.
Yeah, ma'am. So in primary, usually, especially when the elderly primary, when the conception is by some other procedures, and otherwise any history of medication like cocaine drug abuse, but the evaluation does not prove the result of accreta. But sometimes the smoking in the mother also leads to the placenta previa, and also sometimes placenta abnormal placentation and accreta. And most probably that Asherman syndrome, sometimes maybe chances of accreta is there in primary gravida. And also sometimes...
Here, in this case, ma'am, what are the ultrasound findings that you're going to look at? They have reported that it is accreta and there's not invasion. But when we look at the image, what are we going to look for?
And first and foremost, initial ultrasonic finding is the obliteration of the retroplacental space, which is a clear zone. And sometimes there may be thinning of the myometrium, depending upon the severity of the invasion or extension of the trophoblastic invasion. There is other factors associated. But I think it is a simple case. That means it's a simple invasion. We can see initially there is retroplacental space obliteration.
So, Monika Di, do you want to send her for an MRI?
MRI is not
Actually,
very
I think
essential in every
it is
case. Sonography is
simple.
quite sufficient. Of course, MRI is little costly and its availability can be a problem. But
No, but in
MRI
this
will,
case,
when
would
there is
you,
pardon?
in this case, would you want to send her for MRI?
In cases of, if it is clear on sonography, I don't think it will be very necessary to do an MRI, because MRI will tell us the bogginess of the uterine wall, which will say whether it is a placenta accreta or what sort of accreta it is, how much is the invasion, and also we can see the placental bands in that, and moreover we can confirm the placenta previa. So it is not recommended in all cases, of course, but if there is a doubt, we can go for it. It's costly also, its availability is also a little difficult. So,
But in this case, MRI, there is no role because we can see by the sonography itself conformly. But at situation, it
volume is not
needs
clear.
expertise opinion from MRI also. But that is not, there is no need in this case.
Okay. Now, this patient is already 36 weeks. She's a primee. And now she says that, I want vaginal delivery. So what are you going to suggest to her? Dr. Nalini, would you pitch in here? What would you explain to her about normal vaginal delivery or a cesarean section? You're muted, Dr. Nalini.
Yes, ma'am.
Yeah.
Ma'am, I will explain to her, ma'am, that if
Yes.
she wants to go up for vaginal delivery, ma'am, I will explain about the risk of hemorrhage, ma'am, postpartum hemorrhage. And I will suggest her to plan for a cesarean section, ma'am, at around 35 to 36 weeks, ma'am.
Okay. Dr. Vijaya?
In case,
Dr. Vijaya, when this is showing that there is a mild adhesion and not much invasion, what are the surgical considerations? Mahesh Gupta sir has shown us everything. So just in a few lines, what are the surgical considerations?
Madam, I would like to prepare her with adequate amount of blood and keep my enough of sisters and extra instruments ready for the procedure, and give a call if at all any requirement is there.
Ma'am, I'm talking about this case, which doesn't
Yeah.
show much of invasion or anything.
Yeah, I think we can go ahead with delivery and see what if we can do, and see if the placenta could be removed, and with a part of it, whether it is a focal area or entire placenta is involved in that, we can try and remove with a
Now,
finger
before
section.
you think it was a low-lying placenta and she delivered vaginally. Now
then,
what?
Then I would like to go for tocolysis, and if tocolytics, whichever is required and whichever way we can manage, if we can prevent it with medically, I will do. Otherwise, I'll take her up for laparotomy for stepwise devascularization, madam.
See, she has already delivered. It's a light invasion.
Yeah.
Not much, right? Just adhesion.
That's what. If at all,
So,
tocolytics.
are you going to
if
do
I
an
can,
MRP? How will you know?
Yeah.
She has delivered, the placenta has not delivered. What will you do?
I'll wait for half an hour, give oxytocin, and wait for the signs of placental separation. If after and I'll give also oxytocin into 1 ampule of oxytocin into the umbilical cord, and wait if it can separate and it can come out. If at all it is not coming out, I'll try to remove by manual removal. I have done it, and patients have been nicely. Recently, I have done a manual removal of placenta where the placenta has got in there for half an hour and more. but nicely with finger separation, we could deliver out and give ample amount of tocolytics. I mean, oxytocin, prostaglandin, everything was given, and as tranexamic acid, everything, ethamsulate has been given, and we could control the bleeding nicely.
Okay. So,
And I have kept her in ICU for observation all throughout, keeping the patient's attendants informed about if at all requirement of any further bleeding, the requirement of laparotomy, if at all required.
Dr. Nirupama, would you like to say something here?
Blood and blood products, ma'am.
Dr.
Regarding blood and blood
Nirupama?
products, ma'am.
No, I'm asking you, so far, would you want to go ahead and do an MRP, or you would plan for a cesarean, for laparotomy?
Can try for manual removal of placenta.
Okay. So all my panelists agree to that, or somebody differs?
No, we agree.
When there is thoracic hemorrhage, we go for laparotomy.
Initially, we can
first you
try
would
with
go-
manual removal of placenta.
No, when there is the hemorrhage is very heavy and potential hemorrhage is there, then we go for laparotomy. Otherwise, we could go for manual removal.
So when you're going for manual removal, are you going to arrange for blood, and what blood are you going to arrange? Is it going to be whole blood, or is it going to be packed cells? What are you going
It's
to
whole
arrange?
blood. We have to arrange for whole blood.
Massive transfusion pack, ma'am. Massive transfusion pack should be ready.
Fresh
Yes.
frozen plasma also.
Yes. So
Whole
you don't
blood
need
along with
fresh
So
blood.
much contains,
To keep that massive transfusion protocol has to be ready.
Ma'am, is there any road for
Yeah.
check curettage before you go in for a laparotomy?
No.
See, you are going to put in a suction anyways after you've done an MRI, right? After you've done a
MRP.
MRP.
Okay, fine. That makes sense. Okay.
So you'll put a 14 number suction cannula, and you're going to just see everything that it stops bleeding. Dr. Vasudev Panikar has his PPH cannula, which basically works on that principle only, that if the cavity is empty, it doesn't bleed. So that is there. Now we come to the next case, which is a previous cesarean section with a placenta accreta. 34-year-old multigravida para 3, 34 weeks, and deep myometrial invasion is there. Now this is over the cesarean area, right? So how does a previous cesarean increase the risk for placenta accreta? What is the mechanism?
Usually what happens in cesarean section, because of the repeated cesarean section, the scar becomes thin, the myometrium becomes thin, the endometrium also. And as a result of which, when the pregnancy gets implanted there, it, in order to, the placenta infiltrates into the myometrium easily, which is already thin there, and thereby it results in an accreta.
That metabox membrane will be absent in such cases.
Pardon?
So, are you going to be happy with an ultrasound, or you want to do MRI, or you want to do anything else, or you want to add Doppler to your ultrasound? What, or you want to do a 3D? What do you want to do here?
Sonography with Doppler is very useful. It should be done. If an MRI is available, if you want, we can go for it. But in all the studies, whatever it say, that MRI is not very useful. Not very useful. Sonography, a good sonography can be very informative also.
So when you are going to prepare for surgery, what is special about this? You already know there is myometrial invasion. So how are you going to prepare for that?
So first of all, the patient has to be prepared. Then the OT, the surgical team has to be ready, consisting of a urologist, fetal medicine expert, sonologist, anesthetist, intensive care specialist, the pediatrician, and everything. Everyone has to be prepared. And moreover, the blood components have to be ready. The OT, we should have a good ICU for a backup of the patient, this thing for transfusion, everything should be ready. And the patients have to be informed that in case of necessity, she may have to undergo a hysterectomy also.
Okay. So when you are doing a cesarean, Dr. Sushma, if you would put on your video, please. None of you are putting on your videos. It's very difficult to interact, please. Dr. Sushma, Dr. Vijaya. Sujaya. So, what are the complications that you expect? It is adherent only in the area of the scar, nowhere else. So what complications are you going to expect here? Dr. Nalini?
The bleeding will be uncontrolled, ma'am.
No, means
There'll be
are
lot of
you planning on conservative surgery or you are planning on a radical surgery?
I'm planning for a cesarean hysterectomy, ma'am.
Okay, Dr. Nirupama?
If it is only adherent at the scar area, we can try for segmental resection with conservation of the uterus.
Exactly, exactly. Because it's only adherent there. Dr. Vijaya? Dr. Sushma? Narasavani ma'am?
Only it's adherent at a single place. We can go for conservative management.
Okay. Monika Di, what would you like to do?
I would also try for a segmental resection. I would first deliver the baby out. Maybe have to give a incision at a higher place, not the regular lower uterine segment of that area of the scar.
If
Deliver the
it is
baby.
an anterior placenta, which it
Yeah.
obviously is because it is adherent.
Yeah, about the scar. So we will give an incision high up to avoid the scar
It's an
area.
anterior placenta covering the whole anterior wall, and the lower part is now adherent.
Adherent, yeah. Still, we'll try to give the incision at a higher place so that to minimize the bleeding, deliver the baby, leave the placenta there, wait. If it removes, okay, it's all right, and then go for a segmental resection and then repair. And if there is heavy bleeding in spite of that, then what Mahesh sir has told, we will go for those techniques of the uterine arterialization and all.
Okay. So now, when you are counseling this patient, how would you counsel her? You have done her segmental resection and you sutured up. She didn't have any PPH. She's all well. Now she's ready for discharge. So how will you counsel her about future pregnancies?
Placenta accreta spectrum, it can recur. And moreover, the scar is there. The scar always.
But you have already done her segmental resection,
yeah,
right?
We have done, but still there will be chances in a future pregnancy of a placenta accreta. We will, just because she is already gravida for para 3, we will go for a tubectomy also. We'll ask her to go for a permanent sterilization method.
Doesn't agree, wants more children.
She wants more children.
Yes.
I won't advise her to go for more. Of course, she has to explain the risk if she wants.
You can insert a copper T in the same sitting, ma'am, so that she at least has spacing between pregnancies if she wants to plan in future.
Okay. So somebody who has had a placenta accreta, as Dr. Megha had said, that the physiology is different. The type of invasion is different when it is accreta percreta. So what are the management protocols for the future? You've done a conservative surgery. Is there any risk of gestational trophoblastic disease here? Because it has been shown that the mechanism of action is the same. The tumor necrosis factor decreases, and this is how the accreta actually takes place. So how are you going to follow her up in the future?
She needs a long-term follow-up, sometimes years together.
Okay. So what follow-up are you going to do?
In the follow-up, ma'am, as you said, it is a gestational trophoblastic disease. We have to follow up the biomarkers, beta HCG. Usually, when there is any suspicion after, if she is pregnant and conceived, we have to follow up every 6 weeks after delivery. We have to assess the beta HCG evaluation.
Means my first question is this, that are you going to send that placenta and piece of uterus for histopathology?
Actually,
not?
Yes.
in PAS, it is confirmatory diagnosis and histopathological examination, but we are not getting all those things.
Yeah, so that is the take-home point here, is that we need to send that specimen for histopathology.
Yes.
If it is increta, accreta, percreta, whatever, any abnormal placenta has to go for histopathology. Because if you don't send it, you don't know how to follow it up. So then we proceed to the third case. This is a 40-year-old gravida 5 para 4. Now she is 32 weeks and there is bladder invasion. So why are we worried about the bladder? And will she have any symptoms in pregnancy? She's only 32 weeks.
No, ma'am. Nothing.
Hematuria?
No, nothing.
No, nothing. Is it possible to have some hematuria?
No, ma'am.
No.
No.
Everybody agrees to that? If she has complete invasion into the bladder, is it possible to have hematuria?
She may have.
Yes, ma'am.
Actually, no.
She may have
Because
hematuria.
it's
No,
all
ma'am.
covered. Now, the vessels, it's a
No.
hemochoreo placenta. Na? So there is separation, and it would not, if it is covered even with a little bit of membrane, there would be no hematuria. If there is a breach, then there would be hematuria. So now that the bladder is involved, does that change your surgical plan?
Yes, ma'am.
What are you going to do?
So before planning for surgery, we have to keep the along with other all surgeon and obstetrician and gynecologist and senior surgeon, interventional radiologist, and each and everything we have to keep the urologist also.
Yeah,
So
that is very
before-
important. We need a urologist because when the bladder is separated in a previous cesarean, it is the trigone that is actually sitting there.
Yes, ma'am.
So you might need the ureters to be implanted and, you know,
Cystoscopy, ma'am. And stent, ureteric stent.
yes. So how are you going to counsel this patient that, yes, you are 5 times, this is your 5th pregnancy, 5th cesarean is going to happen. You have a percreta now. What is the counseling, content of your counseling to the patient?
We have Dr. Lakshmi ma'am with us. If she wants to add a few points, ma'am, you're more than welcome.
Dr. Nirupama?
We counsel the patient for the cesarean hysterectomy in case of during surgery, and also the involvement of the bladder or ureters and prolonged stay of the hospitalization. So we should prepare the patient and family for that.
Especially when your bladder trigone is involved, then you want to give her special counseling about the bladder.
Bladder involvement. Yes, ma'am.
Because if you put in stents, then those stents have to come out, stent protection has to be done. There are a lot of factors involved in that. And there are many things that can go wrong as well. So other than your routine obstetric consent, the complete urological consent would also have to be taken. So what is the technique that will minimize your complications? Bladder is involved, you already know that, but what is the technique that will minimize complications?
Pre-operation cystoscopy and ureteric stenting, ma'am.
Okay. And
Dissecting the bladder as low as possible.
Cystotomy, ma'am.
yeah, but okay, now you have touched it. You're trying to dissect the bladder, but the placenta is
Placenta
going
starts
inside, right? So you are going to touch it and it's going to bleed. Like sir showed that case, right? You touch the placenta and it starts bleeding. So how are you going to actually manage?
Resection of that part, ma'am, and reconstruction of the remaining bladder, ma'am.
Yeah, means first the blood, you'll have to open the bladder.
Cystotomy. Yes, ma'am.
So the urologist comes in first here. And then the recovery will have to be as per the urologist. This is a case, like sir said, this is a biconvate uterus with placenta previa on the anterior wall. If there is any kind of uterine anomaly, does that increase the risk of accreta or increta percreta?
Yes, ma'am.
Why?
It does.
Because of the but usually the incidence of this adherent placenta is more in bicornuate uterus. There may be in both the corpora of the uterus there is some fibrous bands that may lead to the adherent placenta.
Okay. So if somebody has a uterine anomaly, like for sir, it was a surprise. Suddenly he saw that anomaly. But supposing that patient, you already know that she has an anomaly. So are you going to be extra prepared for that?
Yes, ma'am.
A big bicornuate uterus, like, right? So one side there is the placenta, the other side there is the baby. And you know that placenta is coming down quite a bit. Now it has become accreta. How are you going to manage this? Monika,
In such a case, we will deliver the baby and we will try to remove the placenta, like sir said, conserving the uterus. If it doesn't come out or if it bleeds heavily, in that case, we'll have to, the placental, the biconate portion of the uterus, the portion of the uterus which has the placenta may have to be removed. But that will be, I think, will be a very difficult situation. Of course, I have never encountered that, but I think it will be quite a difficult.
yeah, because bicornuate is different from rudimentary.
From a rudimentary
rudimentary on. It's very different from a rudimentary on. The this procedure will be very difficult, or else we'll have to go for a hysterectomy in such a case.
Okay.
That will be a better option in case she bleeds heavily and we are not able to conserve the uterus.
So how are you going to counsel her about her future pregnancies? You have not taken her to the OT yet. You just have that diagnosis that she has an vast spectrum with a bicornuate uterus. So what is going to be the content of your counseling about her future pregnancies?
Future pregnancies, again, in such cases, will be difficult. She may again end with heavy bleeding, or she may land up in infertility also, or she may, because she may have to undergo hysterectomy also. So that will be a problem. So, and regarding the blood and all the complications that can occur, we have to counsel her properly regarding that.
Okay. So now we come to the second last case, which is a 37-week pregnancy, a routine ultrasound done for growth, and they find that, you know, the retroplacental space is not clear. It's an incidental finding. So how are you going to confirm whether there is something really wrong or not?
Intraoperative findings, ma'am.
No, ma'am.
No,
So
antenatal.
before you take her, she is 37 weeks, right? On an ultrasound, they have written that there is mild accreta.
Ultrasonographic. So ultrasonographic findings are again
Raise
the
the criteria.
operation of the retroplacental filling of the myometrium and lacunae, placental lacunae,
So
And
you
there
want
is
to
probably
do something more here, or you're going to, because she has no symptoms and she
Yeah.
has no significant history as well.
the sonographic findings, ma'am. It is
So
a
what is
probably
the
issue.
Are you going to wait for spontaneous labor, or are you going to do an elective cesarean?
Elective cesarean.
Elective cesarean with the preparation of the patient for the cesarean hysterectomy.
How are you going to convince your patient that, go ahead and have a elective cesarean at 38 weeks?
Because
She has no symptoms. That is the major thing. She has no symptoms.
depending upon
And
the
nobody told her that she has this before 37 weeks. In all her scans, nobody said that.
placental mapping only we can say that if it's persistently the same place, there is no change in place of the placenta. So chance of adhesion is more and invasion is also more.
Okay, so this patient, the placenta is going to come out easily, like Sir said. It's a very mild thing. You do a cesarean, the placenta has come out. But are you going to counsel her something about her next pregnancy or not?
Regarding the recurrence, we'll counsel regarding the recurrence.
You're not going to say anything to her about her next pregnancy? About the spacing, about the chance of recurrence?
Recurrence, yes.
And if you have done a cesarean compared to allowing her to deliver vaginally, have you not already increased her chances of a recurrent increta? Because we said, previous cesarean is one
Definitely it
cause
will
of...
increase. Cesarean will increase the chances of recurrence in the next pregnancy.
So again, think again. Are you going to try a vaginal delivery, or are you going to go ahead and do a cesarean? And how are you going to justify it to yourself and to the patient? Whatever you do. Means I would request every panelist to give their answer. I can see Dr. Nirupama first, then Monika Di, then Dr. Nalini, and then Dr. Narasavani. So Dr. Nirupama?
Ultrasound diagnosed placenta accreta, it is better to go for cesarean section. So actually no idea about doing can we try for vaginal delivery with manual removal of placenta?
See, that was a previous case we had, right? That was a previous case we had where you all said that we'll do an MRP. So this is mild placenta accreta, which is diagnosed on ultrasound at 37 weeks.
Is it previa? If it is placenta previa with accreta,
no, if previa, then to no question. Not a previa,
okay.
Just an anterior placenta.
Okay.
So what do you want to do? You want to do cesarean? You want to do vaginal? Yes, Dr. Narasavani?
We can wait for vaginal delivery. There is no attacks of episodes of bleeding. Then we can wait for vaginal delivery. And if it is not anterior, and we suspect any other rates of placenta previa, you can go for elective cesarean section.
Okay. Dr. Nalini?
Ma'am, actually, we can go for MRI, ma'am, to know the extent of the invasion, ma'am. Depending on that, we can plan.
There is no invasion. It's just adherent.
Still, I want to go for cesarean, ma'am.
Okay.
I think the patient has to be counseled properly, because sonography findings, we can't completely rely on the sonography finding as has been given in the literature and also in the talks before. So if that patient is very much insisting on a normal vaginal delivery, we can go for a vaginal delivery, but explaining her the risk in case she bleeds too much, then we may have to go for a laparotomy also in case we are not able to do the MRP easily, manual removal of the placenta.
So basically, it is a lot of counseling.
Looking at every pregnancy, every pregnancy is very important. And nowadays, I don't think people go for a big family. The first pregnancy is also very important. So we can explain that it's better to go for a cesarean section in such cases to remove the, so that we can easily see the placenta and remove it, and it will be better. But of course, it will increase the risk of a subsequent placenta accreta, may increase the risk.
Okay, so
compared to vaginal delivery.
What is the pregnancy duration when you want to deliver her? Either vaginally or cesarean, but how many weeks are you going to wait? 30, she is 37 weeks now. So you'll wait till 38, 39, 40. What are you waiting for?
39 weeks. Can wait till 30.
Yes, ma'am. At how many weeks do you want to do the cesarean or vaginal delivery? If you want to do induction or cesarean,
39 weeks. 39 weeks.
Completed.
Narsa, ma'am? How many weeks, ma'am?
You can wait till 39 weeks.
Monika di?
I think if she has placenta accreta, which has been diagnosed by sonography, if suppose she bleeds, suddenly she starts bleeding, then a patient will blame us. Ki, why didn't you go
Why
for a
will she
cesarean?
bleed? Why will she bleed?
She may bleed.
No, but without pain, she will not
Yeah.
bleed, no?
Yeah,
Without
Yeah,
going
there are
into
less
labor.
chances. If she has a placenta previa, there will be more chances of it.
No, if she's placenta previa, to सीधे cesarean hai. But if
Cesarean
it
hona
is
hai.
an
But
anterior
placenta
placenta,
हाँ.
then what? Are you going to wait for delivery or you're going to just go ahead and do it?
We can wait.
So WHO says 39 weeks.
Wait for
Yes.
delivery till 38 weeks completed, and once again we have to recheck by the ultrasonic findings. Reconfirm the findings once again.
Okay.
Then plan for 38 weeks gestation.
Cesarean is 39 weeks.
39 weeks. Now, this is a patient. She has a parkrita and she has refused a hysterectomy. She already has 5 children, wants more children. Doesn't want a hysterectomy, whatever happens. So how are you going to counsel this patient? First thing, how many of you are going to actually take this patient? Sixth pregnancy, and she wants to have more children and doesn't want a hysterectomy.
Yeah.
Without cesarean hysterectomy consent, how can we take her for surgery?
Yes.
Agree.
So you're going to take a cesarean hysterectomy consent.
Of course.
Otherwise, she has to go to a higher center.
Higher center. Yeah.
So what do you think about embolization techniques? Before cutting open the uterus, to actually embolize the uterines and then cut open?
We can try embolization.
So it gives
In case it is available.
clear field of the intraoperative field will be clear when there is embolization of the uterine vessels. So the surgeon can easily go ahead with the procedure. But that also has some complications later. There must be intermittent relaxation of the occlusion.
Yeah. So we have done the basic thing that we need to counsel the patient for cesarean hysterectomy and even in cases of conservation about her future. So I would like to have take-home points from each panelist before we end the session.
In all high-risk cases, we have there should be anticipation about placenta accreta.
So in all cases,
yes, Dr. Monika di.
In all cases, a first trimester scan is very important, not only for the dating, but also for the location of the pregnancy sac, so that if it is in the lower uterine segment, we can be more careful right from the beginning that if it is near the skull lower atrial segment, she may land up in Accreta syndrome.
Correct. Narasavani ma'am.
It is very important the sonography of the placental position, situation, and its size and everything. And also, I say something that is, it is always best to avoid number of cesarean sections to avoid these complications in future. And it is also a burden to the obstetrician. Thank you, ma'am. Thank you for your
Thank
work.
you. I have one question which just came to my mind. These days, women are marrying late. They are getting babies late. So supposing somebody has had myomectomy, 20 fibroids removed, and now she has got pregnant. Right? So what should be the content of that myomectomy? And supposing the endometrium has not been breached, will it still affect the chances of Percreta, Increta, Accreta? The endometrium was not breached, the fibroids were removed, but does that still increase the risk of placenta accreta spectrum? You're all very experienced, so just asking you, is it possible?
In myomectomy scars, we never seen any things like accreta, ma'am. Only cesarean scar.
Okay.
Myomectomy scars will increase the risk.
Definitely it will increase. As
But
long
if
as the endometrium is not breached,
not breached, there won't be
any added risk of that's what I feel. As long as the endometrium is not breached, there will not be any added risk of the placenta accreta spectrum disorders. So one should be very careful in preserving the endometrial architecture while doing a myomectomy.
Okay. Okay. Thanks for that. Thank you, Dr. Lakshmi, for pitching in. Nirupama, ma'am. Can't hear you, ma'am.
In the last case, just for discussion, you are saying, can we do embolization and can we leave placenta percreta if somebody is not giving consent for hysterectomy? Can anybody take such cases like that?
Exactly. Provided, but still we need that consent because, but as sir showed you today, that just the uterine embolization would not take care of the anterior and posterior vessels and the patient may still bleed.
If somebody doesn't give consent for cesarean hysterectomy, can we operate such cases?
You need to refuse such cases.
No.
So, Dr. Nalini?
Yeah.
Dr. Vijaya, Dr. Sushma and Dr. Sujayasri, if you would please put on your videos, I would take a photo, please.
Sure, ma'am, we're all here.
Yeah, Dr. Sushma and Dr. Vijaya, I can't see. Dr. Nalini, a comment from you, then from you, Sujaya.
Huh?
Dr. Nalini.
Yes,
Ma'am, asking for a comment from you from closing remark or something. Dr. Nalini, ma'am's asking your take on the topic, take-home message.
okay. Ma'am, since the major risk factor is the previous cesarean sections, ma'am, nowadays we should try to do more vaginal deliveries, ma'am, to avoid these complications like placenta accreta previa.
Okay.
Yes.
Madam, I have a take-home message to point out here. One should remember the 3 Ds. The first D is the diagnosis should be clear and it should be at the right time. Delay, there should not be any delay in intervention. Either be cesarean, you have to do it around 34 weeks. And if she requires a hysterectomy and you're not able to conserve the uterus, there should not be a delay in doing the hysterectomy. And deficiency should always be met with. That is, you need to have proper support system. Be it an obstetrician, be it a senior surgeon, be it a urologist, they should be on board. And also deficiency of blood should be taken care of. So adequate blood. If it is negative group, we should make sure that the donors are available. So that is my take-home message about spectrum disorder. Thank you.
Thank you, ma'am. Thank you.
Thank you.
Yeah.
I think all of us.
He is unable to log in. Vijaya.
Yeah.
Sujaya?
Yeah, so I was thinking that as obstetricians, all of us should be familiar with basic techniques of devascularization and cesarean hysterectomy if required, because these things catch us unawares. Then calling for help, having a senior surgeon come. I mean, you might have time, might not have time. So I think everyone should be well versed in these techniques, at least to save your skin.
Agreed. That was the point of bringing Sir here, because he is the one person who does it day in and day out. All of us would do it occasionally. He does it day in and day out. So
his videos
Dr.
were
Vijaya?
amazing. His videos were amazing. We should have him over again, actually.
Dr. Vijaya? Dr. Sushma? So I think we've been at it for 2.5 hours. And I thank all of you from the bottom of my heart for joining in today and making the evening worthwhile. I thank you so much. This is Searchlight 38. And with all of your support, we are going to take it maybe 138. I don't know. Let us see.
Thank you. Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you.
So now I would stop the live streaming. Namaskar. See you again next Wednesday on precocious puberty. Welcome to the next
Thank you.
Searchlight. Thank you. Good night.
Good night.